Good morning, dear colleagues, dear friends. It's my distinct pleasure to welcome you on behalf of all my colleagues in Institute for Clinical and Experimental Medicine in Prague, and also on behalf of Peter Nožil and his team in Homolka Hospital in Prague. And we believe that you will enjoy next 3 days with us, and you learn something. You will meet some friends, old friends, and make some new friends. And that's how it should be in electrophysiology, because we still are a very exclusive club, I would say, and you will see a lot of new technologies also. So it's a very important meeting for all of us. I would also like to thank to sponsors, because without their help, it would not be possible to make this meeting, and also to CCL company and Media Center company for making all these logistics around. Since Prague is not only the top place for electrophysiology today, but also a very cultural city, we will start this meeting with a matinee performed by Klansky Trio. And Lukáš Klansky will tell you more about this program.
Good morning, ladies and gentlemen. We are very happy to play for you today, and as this year is Year of Czech Music, because many famous Czech composers has anniversaries in 2024. So we definitely play Czech music for you. It will be piano trio by Antonín Dvořák called Důmky, and we will play you only parts of this, because if we play all the trio, it should be too long and you wouldn't have enough time for the reason you are here. But let me shortly introduce my colleagues. These are my siblings, my brother and sister, Adam and Clara. And it's very pleasurable to play with your family, because you don't have to practice together too much, because you feel the music in very similar way, only because you are from one family, so it saves a lot of time. So have a nice days here, and now enjoy Dvořák's music. Thanks. let me shortly explain why I don't play this nice old piano and why I play this electrical one. It's because this one is very old and it's filled with, so we called Viennese mechanic. And the piano is so old that it's now almost untunable. 2 or 3 years ago, I invited a piano tuner, and he told me that he's not able to tune it anymore. So just for your imagination, the sound is nice, very mellow, but it's not very in tune. Yeah, and it's not possible to fix it, but it's still a very nice piece of, let me see, maybe more furniture than musical instrument anymore. So that's the reason why we use this. And now we continue in Dvořák's music. Thanks.
Asi ne.
That's all?
So, Klansky Trio, thank you very much. Just a remark, this concert was not supported from the budget of this meeting, so for some purists...
And I think that it's very important because that level of classic music in Czech Republic, I mean, Klansky family is very famous here. It's not only them, there are more. And actually, it's a big family. And I think that we can continue with that level of, very high level of EP, which we really want to support here. And you know all that we are living some revolutionary era, plenty of changes of paradigm. So actually, I think Pepa, I will ask Pepa to, Joseph Kautzner, Pepa, to get some overview how these changes influence the real practice in Czech Republic in the last year.
Okay, thanks for introduction. And as you all know, I always remind you this initial mission, which was actually the meeting started in 90s because we wanted to train more people in Czech Republic and Slovakia. And finally, it turned to be international meeting. And we still believe that this original mission is very important, but now it's also more than a forum of novel technologies. Since 2008, we actually started to collaboration with the Homolka Hospital with Peter Nouzil, and I believe that it made meeting really very international because now we have capacity to show simultaneously at least 4 or 5 cases together with all new technologies, and Peter is well known for testing of all new technologies. So what are highlights of this edition? We believe that intracardiac echocardiography is very important, and I invited Dr. Rasminia from US. He's one of the experts in intracardiac echo, and also Fermin Garcia, who already presented some of these nice images here, and so this will be very important. And also Maxim Didienko, who is an anatomist. So anatomy and intracardiac echo and online imaging is very important for electrophysiologists today because we do complex cases. Then we will review some different strategies of VT ablation, and we will show you several platforms of pulse field ablation, which is now a highlight of the EP ablation business. And we believe that we will see ablation of long QT syndrome patient from Carlo Papone in Milan. If the patient will not be available, then Brugada syndrome ablation, and then neuroablation or modification of sinus nodes. So just examples of intracardiac echo, as you all know, and some examples of mapping during VT with multipolar catheter. You will see Farapulse cases where you can again use intracardiac echo, because here you see not much about positioning, but here you see how you can really nicely fit. This is if you do it just based on fluoro. Appendage, ridge, and left vein. And if you place it properly, you see that you are covering very nicely this area, but you don't see it on your X-ray. We also will show some cases with Affera, with large footprint catheter, and also other large footprint technology. You see how nicely you can map both atria. This is arrhythmia after ablation of AFib, and you see that it's traveling across both atria through Bachmann's bundle. And the beauty, you can deliver test pulse, and it terminates, so you know that you are on the right spot. I would also like to emphasize that Prague rhythm was the first place where a case of cardio-neuroablation was performed in live worldwide. So it was back in 2015, and you see Dan Wichterle and Dr. Pashon in the center, and Dr. Bashar. This was really breakthrough, because since then this strategy has been adopted more and more, and we also introduced this extracardiac vagal stimulation by Dr. Pashon, where you can really have endpoint for the ablation, and you will see it in a session on Tuesday. And so things moved forward since then, and now it's already also there is a document of ERA on this strategy and ablation type. So just what Peter promised, a few data from Czech registry on catheter ablation. This is probably the oldest registry because we started in 1994, and Dr. Čihák, who is here with us, he's responsible for this registry. Initially, it was like it was organized in amateur way. Now we have everything is digitized, and in a recent year we are testing this platform from Ministry of Health, and they have a special department for these statistics, and it will be done in a professional way. And we can also merge data from this registry with the data from a registry of reimbursement from insurance companies, so we can get the data about mortality, about morbidity, etc. So we are at the beginning of this new era of analysis of data. Czech Republic has more than 10 million inhabitants, and we have 25 centers for ablations. 2 of them are pediatric, so 23 centers for adults. You see that it's somehow distributed across all regions. Of course, Prague has the highest concentration, and then Brno as the second largest city in Czech Republic. This is Prague, obviously, and this is Brno, this is Ostrava. So these are the main cities here. And since this technology has been adopted in Czech Republic quite, I would say, enthusiastically, and many centers use it now, we increased the number of ablations significantly in the previous year, and we did more than 10,000 standard ablations. And you see that there are 2 major centers in Prague, our 2 centers, and then some other centers really moved from the level of 500 to a much higher level, just because of this ease of doing ablation with pulse field technology. So you see here that there are differences among centers. like in Homolka, they do highest number of AF ablations. We do highest number of VT ablations in the Czech Republic. So every center has some different profile. But what is very important that in Czech Republic, very many procedures are guided by intracardiac echocardiography. I would say that most of all complex procedures are guided by intracardiac echo, and you can see that it is sometimes like 90% almost all procedures are guided by intracardiac echo. So this is very important. And also, we are in nice cities, so you can do 3D mapping of Prague. You have many objects to visit, but please, after the meeting, because otherwise we lose here audience. And so I believe that we are facing now a new era in electrophysiology, and we can celebrate this revolutionary progress which is going on now in the last few years, and I'm very excited about this. So thanks for coming, welcome here, and enjoy a time with us.
Many thanks. Actually, I need to add that in Germany, it's exciting era because 2023 they perform 73,000 procedures, and as I calculated, per German population, is less procedures per million per capita than we did here in Czech, first time in the history. They have about 880 procedures per. So we have over 9. So it's very nice. Congratulations to all. And actually, now it's time to introduce the cases from last year. I am really sorry. I need to apologize myself. I need to run to my envelope because we have some other programs now. I really apologize if it was not planned. And please, first ECAM, as always, right? Okay, so who is responsible? Okay, fine, fantastic. So first ECAM and then Homolka, and I need to apologize and wish you a very nice morning. Okay.
I try to handle on your behalf. So, as I said, Nicoletta Ventrella, she's fellow from Milan in our place. She will introduce or recap, let's say, cases from previous edition of the workshop. So, Nikki.
Yes. So, good morning, everybody. My name is Nicoletta Ventrella, and I am an electrophysiology fellow at ICEM. So today it's my pleasure to provide you an update of the patients treated in ICEM during the previous Prague Rhythm workshop. So the first case was an alcohol ablation of ventricular ectopy from the great cardiac vein. The patient was a 58-year-old female without any significant comorbidities, and she suffered from frequent ventricular ectopies coming from the LV summit area. And the patient had already undergone a previous procedure during which RF applications were delivered from the left ventricular endocardium, from the right and left coronary cusps, and also from the great cardiac vein, as you can see in the picture here. Unfortunately, the patient experienced a recurrence of palpitations despite metoprolol, so she was scheduled for an alcohol ablation. On admission, this was the EKG showing ventricular bigeminy. And these are some highlights taken from the procedure. So we started mapping both the endocardium with a pentaray and the great cardiac vein with a decanab. We found the earliest prematurity in the vein, so we decided to proceed with the further mapping with an angioplasty wire, as you can see on the right. And in the end, we performed alcohol ablation with a single balloon targeting the vein in the middle. Maybe, no, you don't see the pointer, okay. After the procedure, the PVC burden reduced to 1%, and the patient is asymptomatic. The next case was the ablation of... thank you. The next case was the ablation of ischemic VT guided by EnSiteX mapping system. He was a very young male patient with a lot of comorbidities. He had a previous anteroseptal STEMI complicated by cardiac arrest and resulting in a very poor ejection fraction and a large epicoseptal aneurysm. The patient received an ICD, which delivered multiple shocks for episodes of fast VT. So at the beginning of the procedure, we induced this tachycardia, which was the clinical one, exiting from the inferior mid-septum, I would say, but the morphology wasn't stable enough to be mapped, so we decided to proceed with the decrement evoked potential mapping, as you can see on the right. So here we have the substrate map performed with the HD grid before the ablation, and on the right you can see the final lesion set, and it demonstrates that we achieved a nice substrate modification. Unfortunately, during the mapping with the HD grid, the patient developed a complete left bundle branch block, so later on he was upgraded with a CRTD, but the device hasn't recorded any ventricular events. So the next day started with the ablation of another ischemic VT with diamond temp catheter, which is a temperature-controlled catheter. Again, he was a 73-year-old male with ischemic cardiomyopathy and a large anterior aneurysm. The patient had an ICD that delivered some shocks, but also recorded some episodes of slow VT that were under the detection rate. The patient was on beta blocker and amiodarone at the moment of the procedure. And again, we performed a decrement evoked potential mapping. And on the right, you can see the substrate map, and the green points represent the annotation of the dips. During the procedure, two different VT morphologies occurred. They were mapped and ablated, and the ablation was also extended to the previous tagged areas. So in the end, we achieved core isolation of the entire aneurysm, and after 1 year of follow-up, the patient, the device hasn't recorded any sustained VT episodes, and the patient is asymptomatic. The next case was another ischemic VT. So he was a 66-year-old male with ischemic cardiomyopathy, previous myocardial infarction, complicated by cardiac arrest, and treated with triple coronary artery bypass graft. Also, this patient had an ICD, and he experienced multiple episodes of symptomatic VTs that were successfully terminated with ATP. So at the beginning of the procedure, despite a very aggressive program ventricular stimulation, we were able to induce only non-sustained VTs originating from the summit area. So we decided to perform a substrate map, and we found a small area of scar located in the perimitral septal region. So this was the target of our ablation, and we delivered also some applications from the right coronary cusp. After 6 months, the patient had only one episode of fast sustained VT that was successfully terminated by ATP. The next case was an IF ablation using high power short duration with the Q-dot catheter. He was a young male patient, an athlete without any significant comorbidities, suffering from paroxysmal AF. At the beginning of the procedure, he was in sinus rhythm, but despite this, with the manipulation of the catheters, AF atrial fibrillation was easily inducible, and it also had the tendency to organize into atrial flutter, typical. So we decided to proceed with the pulmonary vein isolation and also with the CTI ablation. At 9 months follow-up, the patient hasn't experienced any recurrence of atrial fibrillation. Next case, probably the most complex one, was ischemic VT ablation guided by CT imagings. So the patient was a 52-year-old male with ischemic cardiomyopathy and previous myocardial infarction, resulting in a very large anterior aneurysm. The patient had an ICD, which shocked because of an episode of ventricular fibrillation. And 11 years later, he presented with syncope due to VT under the detection rate of the device. So at the moment of the procedure, the patient was on amiodarone and beta blocker. And on the right side of the screen, you can see a 3D reconstruction of the heart of the patient based on images acquired during a CT scan. In dark red, are displayed areas of a thinner myocardial wall, and the white dots represent the suggested target point for the ablation that basically connect these scar islets. So during the procedure, we induced this ventricular tachycardia with a very wide QRS, LBBB morphology, so we thought it could have been a bundle branch reentry tachycardia, and in order to confirm this hypothesis, we paced from the right bundle branch, and as you can see in the right part of the left image, we actually obtained a very nice pace mapping, so basically this confirmed our diagnosis, and so we ablated the right bundle branch. During the procedure, other 3 VTs coming from the upper region of the aneurysm occurred. And in the image on the right, you can see our final lesion set on the images merged with the CT scan. So we followed pretty much what we planned at the beginning of the procedure. Unfortunately, during the follow-up, the patient underwent 2 other VT ablations. The first one was performed with the PF, with the Smart Touch catheter and the galvanized technology. And the second one was an endo-epi RF ablation. So both of the procedures ended with a nice acute outcome without inducibility. But the patient ended up with the heart transplant because of recurrence of electrical storm. Right now, he's doing pretty well. He's in class NIA 1-2, and he hasn't rejected the heart. On the right side, you can see a specimen taken from the recipient heart, and we can see an extensive scar in the anteroseptal area with the fibrous substitution, and also some lesions created during the last RF ablation. The next case was AF ablation with the RF Heliostar balloon. He was a 72-year-old male without significant comorbidities, but suffering from a symptomatic paroxysmal AF despite propafenone. He was in sinus rhythm at the beginning of the procedure, but during the ablation, we recorded temperature rising, so we performed a gastroscopy the day after that showed this lesion here. So 1 month later, the patient underwent another EGDS that showed a complete healing of the mucosa. And at 9 months follow-up, the patient was off any antiarrhythmic drugs, completely asymptomatic, and he hasn't experienced any recurrence of AF. The next case was a zero-fluoro IVNRT ablation of a 59-year-old male healthy patient that presented with a narrow complex tachycardia that was efficaciously terminated by a bolus of adenosine. So the procedure was guided by Carto imaging system. So we started building some matrix with the decanav that was then placed into the coronary sinus, and a Navistar catheter was employed for the ablation. The first RF delivery that lasted for 80 seconds at 50 watts was successful in determining the non-inducibility of the tachycardia. And the patient is off any antiarrhythmic drugs, asymptomatic, without any recurrences. So the last day was dedicated to cardioneuroablation. The first case was, we treated a very young male patient suffering from typical vasovagal syncopes since childhood. And at the TIL test, he had a mixed syncope associated with a long sinus arrest. So on admission, we performed the atropine test, and we were able to achieve a significant increase in the heart rate. And during the procedure, we performed the extracardiac vagal stimulation, and this was the result from the right jugular vein, so we had a significant sinus pause. This is the final lesion set, so as you can see, the procedure was only right-sided, and we targeted only the right anterior GP, and after 1 year of follow-up, the patient experienced only 2 episodes of presyncope. The last case was cardioneuroablation of a 47-year-old female with a history of syncopes. She experienced an intensification of symptoms due to episodes of long AV block. So she was implanted with a dual-chamber pacemaker that was programmed in DDD-ADI. So on admission, again, we performed the atropine test, and we achieved an increase in the heart rate from 73 to 111 beats per minute. During the procedure, we were able to cannulate only the right jugular vein. So this was the result of the extracardiac vagal stimulation performed from that site. So as you can see, we obtained a significant sinus bradycardia. So the procedure was guided by ECVS, and we ended up ablating the right anterior GP, the left superior GP, and also the posteromedial left GP, and from the right side, the left side, and also from the coronary sinus. And after 1 year of follow-up, we programmed the device in AAI DDD, and the percentage of both atrial and ventricular pacing was 0% in the last device check, and the patient had only 4 episodes of presyncope, but not syncope. Thank you very much for the attention.
Thanks, Nikki. And the cases from Homolka Hospital will be reviewed by Dr. Tousek from Prague, from Homolka Hospital.
Okay, so good morning also from me, ladies and gentlemen. And without further ado, let's review our cases. Our first case was a man with ischemic cardiomyopathy and severe left ventricle dysfunction who was admitted with arrhythmic storm, treated with many shocks for untolerated fast VT. He was managed medically with amiodarone. And due to high Pines score, we decided to do the VT ablation on tandem heart support. Mapping showed an extensive scar on anterior wall with a huge number of late potentials. After that, RF ablation was performed with further non-inducibility. Here you can see the late potentials as well as propagation map during RV pacing with the ablation sites. The patient had one adequate shock a couple of weeks after discharge, but since he has been without episodes of VT. Next case was a man with frequent monomorphic PVCs. Looking at the EKG, it was suspected that the site of origin is the LV summit. And that's why the mapping was done both via coronary sinus branch with vision wire, as well as endocardially with a smart touch catheter, where best activation was under the vision wire tip, and ablation was done endocardially with immediate effect. Here you can see a comparison of pace map and spontaneous PVC, and this is a map of the ablation sites. We will have a similar case in this year's edition again with Dr. Garcia. This is a scascopy showing the position of the catheter under the tip of the vision wire, and the patient is doing well with no recurrence. Next case was a woman with persistent atrial fibrillation with previous complex RF ablation. And in this case, it was decided to do the redo procedure both endo and epicardially, and to facilitate the epicardial access, the pericardium was insufflated with carbon dioxide via a coronary sinus branch. After that, both endo and epicardial maps of left atrium were taken, where a reconnection of left superior pulmonary vein was discovered, and as well as the posterior wall was not isolated. Here you can see scascopies from the procedure, and this is a propagation map which is epicardial, showing that the posterior wall was not isolated after the previous procedure. Here you can see the ablation sites. The pulmonary vein was re-isolated endocardially, and the lines were done both endo and epicardially. The patient is doing again very well with no recurrence of AFib. Next case was ablation of ischemic VT. The patient was a man with coronary artery disease and severe left ventricle dysfunction with an extensive aneurysm. He was admitted with a sustained monomorphic VT, which was not tolerated, and a cardioversion was necessary. After that, he was implanted with a biventricular ICD. And during the procedure, at first RBVT was induced with its exit in apical septum. But very soon after that, the patient became very hemodynamically unstable due to many polymorphic unterminable VTs. So an urgent ECMO as well as pulmonary ventilation had to be started. And after that, during VT's mapping was performed, which showed again exit in apical and anterior septum, and the ablation of the substrate was done using ultra-low temperature cryoablation with adagio system in exit sites. After that, no VTs were inducible. Here you can see the console as well as the adagio catheter. These are maps of the scar with a visualization of the catheter. Further hospitalization was complicated with pulmonary embolism, which was treated conservatively with anticoagulation. And in follow-up, the patient had a recurrence of VTs, which in August he was admitted with slow VTs, and a redo procedure had to be done, which was done using RF. And after that, since August, there hasn't been any recurrence. Next case was ablation of left atrium re-entry tachycardia. It was a man with persistent AFib after two ablation procedures, one cryo PVI and one complex PF ablation. And he was admitted with atrial tachycardia, so an activation map was taken, which showed micro-entry originating in mitral isthmus and ridge. After that, in this site, RF ablation was done, and by the end of the procedure, mitral isthmus was not blocked, but no arrhythmia was inducible, so it was ended like this. Here you can see a propagation map where it's clear that the site of origin of the tachycardia is on the ridge. Unfortunately, this patient had a repeated recurrence of atrial tachycardia where 2 DC versions were necessary, so we plan him for PF reablation. Next case was a man with persistent arterial fibrillation previously after complex RF ablation. And the redo procedure started with Carto mapping, which showed right side PV reconnection as well as a signal on posterior wall. And the redo was done using smart touch catheter, but not RF, but PF energy, which was possible thanks to the fact that the catheter was connected to Centauri Galaxy generator. The PF was applied between right side pulmonary veins, and roof line was redone, which you can see on these maps. Again, great clinical effect. The patient hasn't had any recurrence since. Next case was a man with paroxysmal atrial fibrillation, again with prior RF PVI. And first mapping showed that right superior pulmonary vein and left pulmonary veins are reconnected, and the reablation was done using ultra-low temperature cryo with the adagio system. You can see both Pentaray and adagio catheter on this scascopy, and here you can see the final maps after the procedure. Again, the patient is doing very well with no recurrence. And our last case was again a man with persistent atrial fibrillation after repeated DC cardioversions. And at first, standard Farapulse ablation was done, PVI and posterior wall using Farawave catheter. And after that, with the same Farawave catheter using CardioNext mapping system, a voltage map of left atrium was taken, which confirmed that both PVs and posterior wall are isolated after a procedure. Then the procedure was finished with RF isthmus ablation with diamond TEM catheter. Here you can see the maps from the CardioNext mapping system, and again the ablation had great effect. The patient is without recurrence of atrial fibrillation. So thank you very much for your attention.